You are welcome to this lecture on immune mechanisms and immunotherapy. Immune mechanisms and immunotherapy. The immune system is a natural system in multicellular organisms needed to destroy infectious invaders. It is designed to destroy infectious invaders such as microbes or dysregulated cell tumors while leaving normal cells intact. Sometimes microorganisms such as bacteria, viruses, fungal organisms, and so on may invade the multicellular organisms. For example, may invade a human being. Now, these are not usually part of a person. Sometimes a cell which is part of a human being may also go out of control and start multiplying at a rate that is beyond the normal. When humans grow, for example, part of the growth is multiplication of cells. And of course, the cells also grow in terms of size till they get to, quote and unquote, the size for mature cells. But at other times, these cells grow beyond the normal rate, beyond the normal size, as we have it in tumors. So the function of the immune system or the immune response, for example, in humans, is to destroy the infectious invaders, bacteria, like I said, fungal organisms, tumor cells, cancer cells. In order for the immune system to be able to do that effectively, it has to discriminate between self and non-self. The normal cells of the human body, for example, which have not got out of control, are seen as self. The viral organisms, the bacterial organisms, and so on and so forth. Some other foreign bodies that gain access, or foreign substances, foreign particles that gain access into a person's body, are non-self. And so the function of the immune system is to destroy all this so that they don't, these non-self, either organisms or substances, don't overrun the system. We have in this immune response system receptors which sense either the invading microbe or sense cells that have gone out of control. We also have the effector systems that will eliminate these abnormal cells or abnormal organisms. Those receptor systems and the effector systems are contained within the innate and adaptive immune systems. In other words, we have the immune system divided into two broad systems that work to counter infectious invaders and dysregulated self-tumors. These two types of immune responses or immune systems are called the innate immune system and the adaptive immune system. The innate immune system does not need priming. That is, it does not need a situation whereby there is a prior exposure to the invading microbe, for example, before it can start to act against the invading microbe. In other words, the first time an invading microbe comes into the human body, the innate immune system immediately is activated and it starts to counter it. It starts to counter the invading microbe. So the innate system or innate immune system is the first responder when a microorganism invades the immune system or invades the human body. That innate system is broadly reactive. That is, it counters a broad range of non-self, of invading microorganisms, and it is of relatively low affinity. It is of relatively low affinity. When the innate system fails, when it is insufficient to counter a breach of the human body, for example, then the adaptive immune system is called in. That adaptive immune system is antigen specific. It can sense specific invaders. It can sense proteins from specific invading microorganisms. It can sense specific antigen, specific antigenic components of, for example, a tumor. So it is very, very specific, unlike the innate system that is not specific. The adaptive immune system needs priming. That is, there would have been a prior exposure, and that is what we stimulate it to work. So it takes time for it to start working. The adaptive system is learned. So the memory plays a great role to the extent that as long as the body is exposed to the invading microbe or to the cancer cells or tumor that activated the adaptive immune system, the adaptive immune system will usually remember and will usually act against that invading microbe, that invading tumor cell, anytime it rears its head. The adaptive immune system has very high affinity for the invading microbe. Like I said earlier on, the two systems work together. But what happens is that once there is a breach of the body system, for example, by an invading microorganism, the innate system is activated, the innate immune system is activated very quickly. It's the first response system. It is expressed early. It is when the innate system fails, or sometimes when there is need for assistance to the innate immune system, that the adaptive immune system becomes activated. With time, the adaptive immune system becomes dominant over the innate immune system. The major effectors of the innate immune system, that is the components of the innate immune system that affect the fight against an invading microbe, for example, include the complement, the granulocytes, the monocytes, the natural killer cells, mast cells, and basophils. The major effectors of the adaptive immune system are the beta and the T cells, the B and the T cells. The B cells make the antibodies. These antibodies function to destroy the invading microorganism or invading foreign body. The T cells function as helper cells, cytolytic and regulator cells. That is, the T cells regulate the immune system. They act to cause lysis of the invading cells, and so on and so forth. These cells, that is the T and beta cells, mediate the fight against some infections. They have anti-tumor action. They cause tissue rejection and autoimmune reactions. Now, that autoimmune reaction is a situation whereby a certain component of the body, maybe a cell, etc., somehow starts to provoke the person's immune system. So the person's immune system sees that part of self as if it was a foreign body, an invading body, and the immune system starts to counter it, starts to destroy it. That's what we mean by autoimmune reactions. You see that, for example, in some cases of diabetes mellitus, where the immune system destroys some of the beta islet cells in a patient's body. Immunoglobulins or antibodies on the surface of beta cells are receptors for a large variety of specific structural conformations. What I'm saying by this is that on the surface of the B cells, we have antibodies that are produced, or immunoglobulins. They serve as receptors for a lot of either invading foreign substances or chemicals for these foreign substances, thereby promoting an immune response geared towards destroying the invading foreign body. T cells recognize antigens as peptides. T cells recognize antigens as peptide fragments in the context of self-major histocompatibility complex, MHC antigens, called HLA in humans. These are on the surface of antigen-presenting cells, such as dendritic cells, macrophages, and other cell types. So what happens is that these APCs, antigen-presenting cells, they actually get attached to antigens from invading foreign bodies from invading tumor cells. That is, antigens from this attached to the APCs, to the antigen-presenting cells. And it is these antigen-presenting cells that will, in a manner, present these antigens to the T cells. And the T cells will now be able to form antibody these T cells will now be able to form immune reactions. The immune reactions are designed to kill invading microorganisms, to kill cancer cells, and so on and so forth. The clonally restricted cell surface receptors of beta and T cells recognize these specific antigens, as I've said. And once they recognize these specific antigens from the invading cancer cells or other tumor cells, from the invading microbes, the B and T cells start to differentiate, dividing, and they lead to release of soluble mediators such as cytokines and lymphokines that function as effectors and regulators of the immune system. These cytokines and lymphocytes, they regulate the immune system, uptuning it, regulating various processes and procedures there that will eventually lead to the immune system destroying the invading cells or invading foreign bodies. They also produce, this includes production of soluble mediators, like I said, and anything that is needed to destroy the invading organism, to regulate the system so that the system can effectively destroy the invading organisms or invading foreign substances, all of which we tag as non-self. Next, we go to immunosuppression. Sometimes, or whenever there is transplantation, maybe a kidney is transplanted from someone to a patient, into a patient, there's liver transplant, heart transplant, even skin graft or skin grafting. Maybe someone suffers from burns and has lost some part of the skin or had an accident, part of the skin is lost. Then there's transplant, either from a part of the person's body to another part, or from someone else to that person. There will be immune reaction around that transplanted tissue or that transplanted organ. And the immune reaction is just an expression that that transplant or graft was not there originally. So that part of the body where it is transplanted to is not used to it. And the attempt is to reject it. Now, some drugs are administered to patients to suppress the immune response to such transplants, so that the transplanted tissue or organ is not destroyed. And so that takes us to the realm of immunosuppression. Sometimes also, the immune system of a person, for example, may see a part of that person's organ or tissue as non-self. It will just see it as non-self, and it can start destroying it. It happens, for example, in some kidney diseases where the immune system of the person starts to destroy part of the kidney tissues. Also, like I said earlier on, it is also seen in some patients with diabetes mellitus, where the beta islet cells of Langerhans are destroyed by that same person's immune system. We call these last two scenarios autoimmune disease, and there are quite a number of autoimmune diseases that occur like that. The usefulness of drugs to suppress the immune system in the field or specialty that makes use of immunosuppression requires the administration of some drugs that will suppress the immune system so that that organ, that tissue is not destroyed, it is not rejected. Major classes of drugs are used: glucocorticoids, calcineurin inhibitors, anti-proliferative and anti-metabolic agents. I repeat, glucocorticoids, calcineurin inhibitors, and anti-proliferative stroke anti-metabolite stroke anti-metabolic agents. The disadvantages of these immunosuppressive drugs include lifelong use. Usually by the time the administration of these drugs is stopped, the immune system starts to work like before again, optimally, and attempts to destroy that transplanted organ, and so on and so forth, and reject it. Also, when immunosuppressive drugs are administered, there is non-specific suppression of the entire immune system, exposing patients to infections and secondary cancers, especially infections with opportunistic organisms and secondary cancers. You give an immune suppressant, for example, because it is effective in suppressing a cancer. The cancer is immunoresponsive. Sometimes you find out that another type of cancer will now develop in the patient. Calcineurin inhibitors and steroids are particularly nephrotoxic and diabetogenic. Many times they end up destroying the kidneys. They end up causing a rise in the blood sugar level, and the patient becomes diabetic. And this limits their usefulness in certain conditions. Monoclonal and polyclonal antibody preparations directed at reactive T cells are important adjunct therapies and selectively target specific immune reactive cells so that with them we have more specific treatments. We will look at monoclonal and polyclonal antibodies in the next lecture. Sirolimus and anti-CD25 antibodies target growth factor pathways so that whatever it is that was active along the growth factor pathways causing the heightened immune response, etc., can be suppressed. And there is a way they promote tolerance, which is an advantage, because tolerance will eventually lead to the suppression of the immune system response, for example, to an organ transplant without suppressing the general immune response so that the complications of secondary cancers and so on can be limited. We are first going to look at adrenocortical. We are first going to look at the steroids, that is the adrenocortical steroids. These are produced in the adrenal cortex, and a lot of these drugs are now synthesized and used as immunosuppressants, like prednisolone, for example, has been useful over the years as immunosuppressants. What are the mechanisms of actions of these steroids, the adrenocortical steroids? One effect is on lymphocytes. They redistribute lymphocytes such that lymphocytes which would have aggregated at the site of tissue transplant or aggregated at the site of organ transplant, thereby attacking the organ or the tissue and causing tissue rejection or organ rejection, don't accumulate there. They don't aggregate there. By that redistribution, they are distributed in such a way that they are distributed away from that point. And they also lyse lymphocytes. Once the lymphocytes, some lymphocytes are lysed, those lymphocytes are no longer effective. And so in such patients, when you take their blood sample, you will find rapid transient decrease in peripheral lymphocyte counts. Steroids also bind to receptors inside cells. The receptors of glucocorticoid-induced proteins will subsequently bind to DNA in the vicinity of response elements. And once they bind to DNA, it means there will be downregulation of the transcription of numerous genes. And so the proteins that would have been produced, that would lead to the proteins that would have been produced and would lead to formation of immune effectors and so on and so forth, formation of more lymphocytes are not produced. And so the immune response against the transplanted tissue or organ remains as low as possible to prevent rejection. Glucocorticoid receptor complexes, that is, the complexes formed by the glucocorticoid, that is, the adrenal cortical steroid binding to its active receptors, will also, when the steroid binds to the receptor, they form complexes. These complexes will also increase IKB expression. When they increase IKB expression, it means NF-κB activation will be stepped down. It will be suppressed. And so, cells of the immune system that would have been produced and would have tackled the transplanted tissue or transplanted organ will now die. What we call self-regulated death. The cells die in a manner we describe as apoptosis. I'm sure you've come across apoptosis before, which we define as regulated cell death. Normally, there is a regulated system that some of the cells produced in the body die naturally from time to time. So glucocorticoid receptor complexes, when you administer adrenocortical steroids and it forms receptor complexes, with its receptors. It increases the rate of apoptosis of cells of the immune system, lymphocytes and so on, that would have countered a transplanted tissue or transplanted organ. One of the importance of this is that there is downregulation of important pro-inflammatory cytokines, such as interleukin-1 and interleukin-6. The T cells are inhibited from making interleukin-2 and from proliferating. Therefore, you have less T cells action, less interleukin actions. So the inflammatory responses that would have caused aggregation of cells of the immune system, especially lymphocytes and so on, that would have destroyed the transplanted tissue. Such inflammatory response will be downregulated, and the activation of the cytotoxic T lymphocytes is also inhibited. These cytotoxic lymphocytes are the ones that would normally kill the cells of the transplanted tissue, kill the cells of the transplanted organ. Neutrophils and monocytes display poor chemotaxis whenever a patient is administered adrenocortical steroids. Therefore, it is obvious that glucocorticoids have broad anti-inflammatory effects on cellular immunity. Cellular immunity, that is immunity that is carried out by the T and B cells. But glucocorticoids have relatively less effect on humoral immunity. Look at all what we've just said. You see that the effect is more on cellular immunity. What are the therapeutic uses of adrenocortical steroids? They are useful in prevention and treatment of transplant rejection. Prevention and treatment. Preventing transplant rejection is one thing. Treating transplant rejection, that is when rejection has ensued, is another thing. Glucocorticoids, or otherwise named adrenocortical steroids, are effective both in prevention and treatment of transplant rejection. They are also useful in rheumatoid and other arthritis, SLE, asthma, and other allergic conditions. Toxicities of steroids are numerous. That is glucocorticoids or adrenocortical steroids. They are numerous. Those will be dealt with in another lecture. I'm just going to mention a few. Growth retardation in children, hypertension, hyperglycemia infection, osteopenia, bones, bone growth is limited, and then there is loss of calcium in the bone to the extent that fractures can develop with time. Next, we look at calcineurin inhibitors. Calcineurin inhibitors like cyclosporine and tacrolimus. Cyclosporine and tacrolimus. They are very effective. They inhibit normal T cell receptor activation by inhibiting intracellular signaling. Once they inhibit the signaling in the cells, then T cell receptor activation is downplayed. We first start by looking at cyclosporine. Cyclosporine is more effective against T cell dependent immune mechanism, that is transplant rejection and autoimmunity. This transplant rejection and autoimmunity are things that are caused more by the T cells. It's the T cells that are really active against transplant and active in autoimmunity or autoimmune diseases. Cyclosporine will inhibit antigen-triggered signal transduction in T lymphocytes. So once a foreign body, a microbe that falls into the class that T lymphocytes will act against, once it invades the body, once it is in the body, it may be a tumor cell, a cancer. Cyclosporine, when you give cyclosporine, I'll take that again. When you give cyclosporine to a patient, cyclosporine will inhibit antigen-triggered signal transduction in T lymphocytes. Why is this useful? For example, there is autoimmunity. There is autoimmunity. That is, the person's body is acting against a component of the body. The body is responding to self as if it is non-self. What cyclosporine is useful for in that case is that cyclosporine will inhibit the T lymphocyte function that would have been triggered by the presence of antigens, to which T lymphocytes normally would have acted against in autoimmunity. The T lymphocytes, what happens is that the T lymphocytes, some antigens are produced, for example, in a part of the body. And so the T lymphocytes sense those antigens. And in attacking those antigens, will also destroy part of the body, maybe the tissue on which the antigen is produced. That's what happens in autoimmune disease. Now, what cyclosporine will do is that cyclosporine will inhibit the signaling that gets to T lymphocytes from such antigens. The end result is that that part of the human body is not destroyed. And if it is a transplanted organ, for example, that transplanted organ will not be destroyed by T lymphocytes. And many lymphokines expressions will also be blunted by cyclosporine, including interleukin-2 and expression of anti-apoptic proteins. Cyclosporine acts by forming a complex with cyclophilin. That cyclophilin is a cytoplasmic receptor protein present in target cells. We have a target cell. Maybe the target cell, for example, is found in a transplanted tissue. Normally, you transplant the tissue, like the skin. You don't want the skin to be attacked by the immune system. But what normally will happen is that cyclophilin is normally present in the cytoplasm of these target cells. And that cyclophilin, the cyclophilin is one of the things that is responsible for the immune response against the target cells and therefore the target tissue. What cyclosporine does is that it will form a complex with it, with cyclophilin. And that's one of the ways cyclosporine will prevent the immune response that would have destroyed those cells and the tissue in which they are contained, the transplanted tissue, for example. Because that complex formed by cyclosporine, or I'm explaining further now, that complex formed by cyclosporine and cyclophilin will bind to calcineurin. When it binds to calcineurin, there will be inhibition of this phosphorylation of the cytosolic component of end fat. With the inhibition of that dysphosphorylation, it means the T cell, the T lymphocytes will not respond to the antigenic stimulation. And so those cells and the tissue in which they are contained will be spared. If cyclosporine was not administered to that patient, the phosphorylation would have occurred. And once the phosphorylation occurs, T cells will respond, that is, T lymphocytes will respond to specific antigenic stimulation. But now, because the patient has been given cyclosporine, cyclosporine has bound to cyclophilin. Cyclophilin has now, that complex of cyclosporine and cyclophilin has now bound to, is now bound to calcineurin, and calcineurin is now inhibiting the phosphorylation of cytosolic component of end fat. Once that dephosphorylation is inhibited, that is, dephosphorylation cannot take place, then whatever specific antigenic stimulation that occurs, the T lymphocytes will not recognize it, and the T lymphocytes will not be activated to destroy those target cells, will not be activated to destroy that tissue. What are the therapeutic uses of cyclosporine? It is useful in organ transplant. It is useful in rheumatoid arthritis and psoriasis. One problem with cyclosporine is the drug interactions it has. It interacts with quite a number of other drugs because the microsomal enzymes in the liver that metabolize cyclosporine also metabolize these other drugs. Especially the CYP3A microsomal enzymes, especially the CYP3A microsomal enzymes. So verapamine, nicardipine, fluconazole, ketoconazole, indanivir, methylprednisolone, allopurinol, erythromycin, when given or administered concomitantly with cyclosporine, what will happen is that cyclosporine concentration will be increased in the patient's systemic circulation. Cyclosporine concentration will be increased in the patient's systemic circulation. Whereas other drugs like nafcillin, rifampin, phenobarbital, phentoin, octreotide, and so on decrease cyclosporine concentration. Why will they decrease cyclosporine concentration? Because they induce the microsomal enzyme CYP3A. When they induce the action of CYP3A, CYP3A will act more rapidly, and we metabolize cyclosporine more rapidly and to a greater extent, so that the concentration of, so that cyclosporine is more rapidly cleared from the system, it's more rapidly eliminated, so its concentration will reduce. Whereas the other drugs I mentioned first, verapamil, nicardipine, and co, will inhibit CYP3A metabolism of cyclosporine and cause reduced clearance of cyclosporine in the system. The next drug we are looking at is tacrolimus. Tacrolimus. It is a macrolide antibiotic produced by Streptomyces. What is its mechanism of action? Tacrolimus binds to intracellular protein FK506 binding protein. When it binds to it, it forms a complex of tacrolimus FKBP12. Tacrolimus FKBP12. Also in that complex, we have calcium, calmodulin, and calcineurin. And what happens is that the activity of calcineurin phosphatase is thus inhibited. The activity of calcineurin phosphate is, the activity of calcineurin phosphatase is therefore inhibited, because that complex of tacrolimus, FKB12, calcium, calmodulin, also is complex with calcineurin. Once it is complex with calcineurin, calcineurin phosphatase activity will be inhibited. And all this will prevent dephosphorylation and nuclear translocation of end fat. Once that happens, once this phosphorylation does not occur, just like in the former situation, then T cell activation is inhibited. And of course, it means T cells will not sense the usual antigenic signals and will not be able to act against an organ that has been transplanted or a tissue that has been transplanted. It is. What are the therapeutic uses of this drug? It's used in prevention of solid organ allograft rejection. It's used as rescue therapy among patients with rejection episode, despite therapeutic levels of cyclosporine. So if you place a patient on cyclosporine, and you can see that the rejection of transplanted organ is still ongoing, then the best thing, then what is done at times is to also give this drug, tacrolimus, to the patient, a macrolide, like I said, and it is found to be effective in rescuing, the rejection episode. The toxicity spectrum is wide. Nephrotoxicity, neurotoxicity, hypertension, hyperkalemia, hyperglycemia, diabetes, and even GIT complaints. There are still some others, apart from this, but these are the major ones. Particularly, you find those that are of major concerns there. What are the drug interactions of tacrolimus? Now, the blood levels of tacrolimus and renal function tests should be monitored closely, including when patients are on other nephrotoxic drugs. It is also metabolized by CYP3A enzyme. Hence, the same range of drug interactions as we mentioned for cyclosporine occur here. Next, we are going to proliferative and anti-metabolic drugs. We look at sirolimus. We look at this drug, which is also produced by streptomyces. What is the mechanism of action of sirolimus? It forms a complex with the immunophilin FKB12. FKB12 is coming up again. This complex binds to and inhibits mammalian kinase. It binds to and inhibits mammalian kinase, target of rapamycin. Now, this mammalian kinase, which is target of rapamycin, is a key enzyme in cell progression. This inhibition blocks cell cycle protection at G1 to S phase transition. Once this phase, G1 to S phase transition is blocked, then it prevents, for example, tissue rejection. Its effects last several months after discontinuing therapy. Its effects last several months after discontinuing therapy. It means for several months, this G1 to S phase transition is still blocked. It is still blocked. And if it is still blocked, it means, for example, tissue rejection will still be put on hold. It will still be suppressed. And this suggests a tolerizing effect. What do we mean by tolerizing effect? Tolerizing effect is coined from tolerance. When we say tolerance, it means something is accommodating, something is now used to a procedure or a system or an occurrence that it won't react, against that thing. Now, normally, when immunosuppressants are administered to a patient, the immunosuppressant will also suppress immune response to invading microbes, will suppress immune response to cancers, and so on and so forth. So the tendency is that, like I said much earlier in this lecture, while a patient is on an immunosuppressing or immunosuppressive drug, the tendency is that infections can creep in and the patient can succumb to infections and die of infections, pneumonia, and so on and so forth. Also, if the immunosuppressing agent or immunosuppressive agent or drug has been administered because the person has a cancer and the cancer is found to be responsive to immunosuppressants, that is, immunosuppressants inhibit the cancer growth. While that cancer is being treated, some other cancers may crop up because the general immune system is suppressed. And so the general immune system is not able to suppress the growth of other cells, the rapid multiplication of other cells, the distortion of other cells, and so secondary cancers can occur. However, with a drug like sirolimus, when it is administered, what happens is that there's a kind of tolerance of the immune system to it. The immune system can still function against some invading microbes, against some other cells that would have become cancerous, while its effect on maybe the cancer cells for which it was administered in the first instance, or whatever tissue transplant or whatever that for whatever it was applied for, the effect is still maintained. So it's like we are having our cake and still eating it. And that's one advantage of sirolimus. That's one good advantage. Another immunosuppressive agent is azathioprine. Azathioprine is a purine metabolite and imidazole derivative of 6-mercaptopurine. 6-mercaptopurine. Next, we are looking at the mechanism of action. Azathioprine is cleaved to 6-mercaptopurine once it is exposed to nucleophiles. And 6-mercaptopurine is in turn converted to additional metabolites. Those additional metabolites inhibit de novo purine synthesis. 6-tau-IMP, a fraudulent nucleotide, is converted to 6-tau-GMP, and finally to 6-tau-GTP. That 6-tau-GTP is incorporated into DNA of, for example, a cancer cell that is susceptible, or incorporated into the DNA of the immune cell, and gene translocation is therefore inhibited. Gene translocation is therefore inhibited. Cell proliferation is prevented, and so lymphocyte functions are inhibited. Lymphocyte functions are inhibited. Another drug we are looking at is mycophenolate mofetil. It is a prodrug. It is rapidly hydrolyzed to the active drug mycophenolic acid. That mycophenolic acid is a reversible inhibitor of inosine monophosphate dehydrogenase, which is an important enzyme in the de novo synthesis of guanine nucleotide. B and T lymphocytes are highly dependent on this pathway for cell proliferation, while other cell types have salvage pathways. Now, antibody formation, cellular addition, and migration are therefore inhibited by mycophenolate mofetil. And mark you, I said B and T lymphocytes are highly dependent on the pathway upon which mycophenolic acid works. And so it's effective against B and T lymphocytes function as an immunosuppressant. We also have methotrexate. Methotrexate has been useful for graft versus host disease, has been useful in rheumatoid arthritis, psoriasis, and cancer. Cyclophosphamide is another immunosuppressant, another immunosuppressive agent that has been useful for years. It has been useful, for example, in treatment of childhood nephrotic syndrome, treatment of malignancies, severe systemic lupus erythematosus. Chlorambucil has also been useful in childhood nephrotic syndrome and some malignancies. Leflunomide is a pyrimidine synthesis inhibitor. It inhibits dihydroorotate dehydrogenase in the de novo pathway of pyrimidine synthesis. It has been useful in the treatment of rheumatoid arthritis. In summary, we've looked at the immune system. We've discussed that the immune system is divided into two broad classes in terms of the response got when a microbe invades the human body, for example, or there is a tumor or other foreign substances invade the human body. The innate immune system, which is the first port of call once the immune system is called up, once there is need for the immune response. And the next class is the adaptive immune system. We've looked at their different characteristics, including the fact that the adaptive immune system is more specific, that the memory function is a critical characteristic, and so on and so forth. We've looked at immunosuppressant agents. We looked at adrenocorticosteroids. We looked at tacrolimus. We looked at cycloserine. We looked at sirolimus. We looked at methotrexate. We also considered mercaptopurine, and so on and so forth. We've seen their mechanisms of action, that invariably what happens is that most of them work at inhibiting T cells or T cells and B cells function, so that they don't counter transplanted tissues, grafts, and so on and so forth. We've seen that generally they function by working, intracellularly, being incorporated in the DNA and regulating specific genetic functions that would have produced the proteins needed in assembling the cells and the other components of the immune system. Once they downregulate the production of these proteins, they downregulate the signaling and the attraction of the T and B lymphocytes to target cells, so that T and B lymphocytes don't destroy target cells, don't destroy, therefore, the tissues and the organs in which these target cells are. We've seen the various adverse drug reactions, and we noted that sirolimus is of a particular advantage because it appears that tolerance is developed to the function of sirolimus. Thank you for being a part of this class.